Hello everyone, my name is Daslinawati Dodd. In this video I will share about National Health Insurance Model. National Health Insurance (NHI) is a system of health insurance that insures a national population against the costs of health care. The National Health Insurance Model blends different aspects of both the Beveridge model and the Bismarck model. First, like the Beveridge model, the government acts as the single payer for medical procedures. However, like the Bismarck model, providers are private. Private providers drive the National Health Insurance Model, but the payments come from a government-run insurance program that every citizen pays into. Essentially, the National Health Insurance Model is universal insurance that does not make a profit or deny claims. Since there is no need for marketing, no financial motive to deny claims, and no concern for profit, it is cheaper and much simpler to navigate. This balance between private and public give hospitals and providers more freedom without the frustrating complexity of insurance plans and policies. The primary criticism of the National Health Insurance Model is the potential for long waiting lists and delays in treatment, which are considered a severe health policy issue. The classic NHI system is found in Canada, but some newly industrialized countries such as South Korea and Taiwan have also adopted the NHI model. NHI programs differ both in how the contributions are collected, and in how the services are provided. In countries such as Canada, payment is made by the government directly from tax revenue, and this is known as single-payer health care. The provision of services may be through either publicly or privately owned health care providers. In France, a similar system of compulsory contributions is made, but the collection is administered by non-profit organizations set up for the purpose. An alternative funding approach is where countries implement national health insurance by legislation requiring compulsory contributions to competing insurance funds. These funds must provide a minimum standard of coverage and are not allowed to discriminate between patients by charging different rates according to age, occupation, or previous health status. To protect the interest of both patients and insurance companies, the government establishes an equalization pool to spread risks between the various funds. The government may also contribute to the equalization pool as a form of health care subsidy. This is the model used in the Netherlands. Other countries are largely funded by contributions by employers and employees to sickness funds. With these programs, funds come from neither the government nor direct private payments. This system operates in countries such as Germany and Belgium. These funds are usually non-profit institutions run solely for the benefit of their members. These systems are characterized by a mixture of three sources of funds in varying degrees: private, employer-employee contributions, and national, subnational taxes. In addition to direct medical costs, some national insurance plans also provide compensation for loss of work due to ill health, or may be part of wider social insurance plans covering things such as pensions, unemployment, occupational retraining, and financial support for students. National schemes have the advantage that the pool or pools tend to be vast and reflective of the national population. Health care costs, which tend to be high at extremes of age and other specific events in life, such as during pregnancy and childbirth, can be contributed to the pool over a lifetime. This differs from the private insurance schemes that operate which to price insurance year on year according to health risks such as age, family history, previous illnesses, and height-weight ratios. Consequently, some people tend to have to pay more for their health insurance when they are sick and/or are least able to afford it. These factors are not taken into consideration in NHI schemes. We see healthcare system in Taiwan as example. Healthcare in Taiwan is administered by the Ministry of Health and Welfare of the Executive Yuan. Taiwan established a system of universal NHI in March 1995. It is a government-administered insurance-based national healthcare system. Taiwan has a single-payer system for healthcare and covers 99% of the total population. Every enrollee has a health identification smart card. This credit card-size card contains 32 kilobytes of memory that includes provider and patient profiles to identify and reduce insurance fraud, overcharges, duplication of services and tests. The physician puts the card into a reader, and the patient's medical history and prescriptions come up on a computer screen. The insurer is billed the medical bill, and it is automatically paid. Taiwan's single-payer insurer monitors standards, use and quality of treatment for diagnosis by requiring the providers to submit a full report every 24 hours. This improves the quality of treatment, limits physicians from over-prescribing medications, and keeps patients from abusing the system. Taiwan has the lowest administration cost in the world of 2%. The system promises equal access to healthcare for all citizens. The NHI system consolidated all these small insurance schemes into a single national insurance system. The National Health Insurance Administration (NHIA), set up by the government, reimburses the contracted institutions for the services provided. A national health system may be financed by taxes, premiums, out-of-pocket payments, or some combination of the three. From 1995 to 2012, Taiwan used premium financing, with premiums derived from regular payroll income constitutes approximately 60% of Taiwan's total national income. However, government premium subsidies based on general taxation for specific population groups play a role in the NHI's overall financing. In January 2013, a supplemental premium scheme based on 6 sources of income not based on a regular payroll, bonuses, professional fees, pay for second jobs, interest, dividends, and rents was introduced as an essential part of a major reform known as the Second-Generation National Health Insurance Reform. The new premium base draws on over 90% of Taiwan's total national income. People insured by the NHI are categorized into 6 population groups, based mainly on occupational status. Premiums are levied on members of the 6 groups that make up the program's insurance pool. Taiwan's health care delivery system is a mixture of private non-profit and government-owned hospitals, private clinics, and other health care facilities. For-profit hospitals are not allowed in Taiwan. The health insurance Taiwan provided is comprehensive. Both inpatient and outpatient care are covered, as well as dental care, over-the-counter drugs and traditional Chinese medicine. Taiwan's providers derive revenues from 3 sources: NHI payments, copays by patients, and the sale of services and products not covered by the NHI. For employees in public or private enterprises, the shares are 30%, 60% and 10% respectively. The high-income self-employed insured pay 100% of the premium themselves. The government pays 100% of the premium for military personnel and the low-income unemployed and pays 40% of the premium for the other unemployed. The amount collected by the NHI in respect of each enrollee varies according to his or her number of dependents, although dependents above 3 are adequately insured for free. These insurance premiums are supplemented by smaller contributions from co-payments, alcohol and tobacco taxes and lottery revenues, and recompense from national environmental pollution funds and automobile insurance. In 2008, total national health expenditure was $23.9 billion or 6.4% of gross domestic product (GDP). Exchange rate 33 NTD 1 United States dollar. Fee-for-service is the predominant payment method for providers under the NHI's global budget system. The implementation of universal healthcare created fewer health disparities for lower-income citizens in Taiwan. Additionally, life expectancy increased more in health class groups that had higher mortality rates before national health insurance was introduced. Life expectancy in Taiwan is about 80 years old as of 2018. The infant mortality rate is low, and only 4 deaths for 1,000 live births, as well as fertility rates are very high and stable. Healthcare is much more thorough and supported than it is in America. As a modern-day country, Taiwan has shifted its approach to allow its country to set structures and functions for other countries to follow. Although there are many different people to tend to include the disabled, Taiwan has catered to its best ability and also supported more than 23.4 million citizens to provide this universal healthcare. This nation has focused more on the medical aspect of health care instead of administrative or economy, which is why everyone is succeeding, especially the disabled who need guidance and support because of sensitive circumstances. That brings me to the end of my video. Thank you for your attention. References.